So thank you for inviting me to give this talk, and I will share in the next 15 minutes, I guess, the experiences we have with the Umbrella Fit study, which is an exercise trial within the hospital-based breast cancer cohort we have in our hospital. I will start with telling you something about the Umbrella cohort so that you can understand the base of our trial, and then I will go in more details about the Umbrella Fit study. So the Umbrella cohort was started 3 years ago, and it's an acronym for Utrecht Cohort for Multiple Breast Cancer Intervention Studies and Long-Term Evaluation. Within this cohort, all patients who come to the radiotherapy department are asked whether they are willing to participate in our cohort study. And if patients agree, we collect medical data, so data on their tumor, treatment characteristics, and also side effects of their treatment. Next to that, we ask patients to regularly fill in patient-reported outcome measures, questionnaires, to get information on their quality of life, fatigue, and other issues that are related to their disease. The Umbrella cohort is a cohort that is not dedicated to one type of interventions in cancer patients, but it's established to investigate very different interventions. So that could be radiotherapy interventions, chemotherapy interventions, but also apps could be evaluated, or a physical exercise program such as we do in the Umbrella Fit study, but also studies on lymphedema, which is a side effect of the treatment, could be studied within the cohort. So this is the informed consent procedure we use in Utrecht, and this is also what our medical ethics committee agreed on. So what we do, we have 2 stages. There's stage 1, so all patients who come to the radiotherapy department are asked for consent. First, consent for the cohort, so that means that we can obtain their medical data and that they fill in the questionnaires. Then they get a second question, whether they are also willing to be randomized in the future for intervention studies, and that they may serve as controls, which means that they won't be informed about the actual study we run at that moment. Then there's a second stage, and this second stage can occur within an hour, a week, a month, or years. So that is when we have interventions we would like to study in the cohort. And one example is the Umbrella Fit trial I will talk about. And here we only ask for the second stage informed consent 12 to 18 months after recruitment. So when their primary treatment for cancer has already been completed. And this second stage is only for the intervention group, because the control group already gave their consent in the first stage. So here I show you shortly numbers on our cohort. So we started 3 years ago, and we now have over 1,500 patients in the Umbrella cohort. 87% of the patients gave informed consent for the second stage, so to be randomized to interventions or serve as controls. And the return rate of our prompts is between 67% and 80%, dependent on the moment in time. And as you can see there, we do have more cohorts in our hospital. I won't go in details, but my colleagues who will also present here will tell you more about the other cohorts we have. So let's move to the Umbrella Fit study. And before I tell you more details about it, I will just give you some background why we decided to initiate such a study. The Umbrella Fit study is a feasibility study where we really test the feasibility of a cohort randomized controlled trial within the Umbrella cohort to study the effects of exercise on quality of life of breast cancer patients. A couple of years ago, I performed the PACT study. This was a conventional RCT. You can see it here, and you already saw this scheme today. So we asked patients whether they were interested to participate in an exercise study that was during their breast cancer treatment. And after consent, we randomized the patients to the intervention arm or the control arm, which means no exercise during the chemotherapy. So here, the question to the patient was typically, do you want to participate in an exercise intervention study during your chemotherapy with 50% chance that you won't get it. And you can imagine that in such a time where you just had a diagnosis of breast cancer and you face the chemotherapy, that this is a quite difficult question. And also the problem here is that it is an intervention you cannot blind. So the control patients will know that they don't get it. So what happened? Either patients beforehand decided that they do not want to participate. So recruitment was hard. And the second thing was that patients either dropped out after being randomized to control because they thought, oh, let's go for that 50% chance to get the intervention. And when they didn't get it, they told us, okay, I will drop out. Or, and this was also severe in our study, over 50% of the control patients exercised the same amount as we asked our intervention group. So and that is a problem for your effect size at the end. So when we performed the trial and during the analysis, I was really thinking that perhaps the CMRCT design, so we still call that so in the Netherlands, or it's the TWIX, but might be a good solution to all the problems I just told you. But we also do not know whether it's feasible, because you must imagine that it's a time-consuming intervention. And you randomize a person and you ask this person, do you have time the coming 12 weeks to come to our center twice per week for the exercise? So I decided before really doing serious effectiveness studies, let's do a methodological study and really test whether this is a feasible design for these types of studies. So here you see the scheme of the umbrella cohort, this prospective cohort, recruitment at radiotherapy, and then regular follow-up measurements in the cohort. What we did is we defined a subpopulation in the cohort that were women 12 to 18 months after recruitment and also inactive. And for that inactivity, we used their physical activity questionnaire they filled in at that moment. From this subpopulation, we randomly selected an exercise group and also a control group. And only the exercise group received first a letter and then a telephone call with the question, we offer you an exercise intervention, do you want it? So this question is somewhat easier than the first question. And the control group was not informed, and we used the measurements we have here in our cohort to get our outcome measures. So this design might have possible benefits, but also there might be possible disadvantages, and that is why I do the study. So to start with the benefits, now the control group is unaware of the trial. So this means that there's no or less dropout in the control group after randomization, no contamination, because the control group patients do not know that they are in the trial. It might well be that they also start exercising, but then this is a sort of real world. It's not that, because the problem in our exercise trials is that patients start exercising because they are in the study. And it's not that it's what they usually do. So it's not a problem if they start exercising, because then it's more real world evidence. And furthermore, we also think that using this design might lead to faster recruitment, because we now already have the pool of patients and don't need to recruit from several sources. And we also have the advantage of long-term measurements that are just done within the cohort. But, as I already said, it might well be that the dropout in the intervention group is higher, because now you have this how we do it is we just send a letter to the patient that they are selected for the intervention and ask them whether they want to have it or not. Then we call them to discuss further procedures. And it might well be that many patients say, okay, this is a great idea, but I have no time to it, or I'm not interested, or something like that. And that's only if we have enough patients who say, yes, this is we will be able to get our results from the trial. And second, it might also be that dropout during the intervention is higher, because now we have a somewhat different sample as we have in conventional RCTs, where patients beforehand decide that they are motivated for the intervention, and now it's only that they get the question and then they think, oh, let's try it. And a second disadvantage is that we are restricted to data from the cohort. So for the definition of the eligible subpopulation, we can also only use the data we have in the cohort. But we have no real-time data on for example, comorbidities or injuries. So for example, knee injuries, shoulder injuries. And this is quite difficult because you randomize people to the control, to the exercise intervention. All these patients will stay in your analysis, in your intention to treat analysis. So it might be that there are patients in your sample that are not able to exercise at that moment. And the other thing is that, of course, you can only measure outcomes you measure in your cohort. So that is also a restriction. But of course, you can decide beforehand to have a cohort with the outcome measures you need for your study. So the objectives of the trial are, as I already said, is first to determine the feasibility of the design in the field of exercise trials in cancer patients, and also secondly to examine the effectiveness of our intervention. We aim to include 166 patients. Here in our sample size calculation, we did account for some dropout in the intervention group, and also the intervention will be a 12-week supervised intervention. Just to give you a very quick idea what we ask our patients to do. It's a 12-week program, 2 one-hour supervised fitness sessions per week with cycling and strength exercises. We choose to have these exercises near the patient's home so that there's not that threshold of long travel distances. Furthermore, we ask patients, and that's quite a hard one, perhaps if you think about your own activity style, we ask them to be active every day for at least 30 minutes a day, and we also try to reduce sedentary, so sitting behavior, what you all do now in our study, by using an activity tracker which alerts you when you sit for longer than 45 minutes. So these are the intervention patients are asked to say yes to. But of course, these are interventions we already have in practice, and we know that it's feasible. So we know that patient can do it, at least. The outcomes will be, the methodological part, the compliance in both group, participation rate and intervention compliance. We have data from other exercise trials, so we can compare our rates to all these other trials. We will look at dropout in both groups, and of course the effectiveness measures. So where are we at the moment? First, I would like to acknowledge my PhD student. She's here in the audience because she's really doing all the work and she's calling all the patients. And I think in the beginning it was best, we didn't know what to expect, just calling patients and talking about the exercise program. So she now has a lot of experience with that. So what we did, we started in October last year. We now included 130 of the 166 patients, 65 in the intervention group and 65 in the control group. What you can see is that by now 55% said yes, 3% said maybe later, and 40% said no. So that's quite a high amount, and I will come to the reasons patients told us in a minute. The other thing I would like to point out here is the age of the patients, because they are on average 58 years, and normally in our breast cancer exercise trials we see patients who are on average 50 years, 50, 51. So that shows us that with this design we are able to recruit patients who would never agree in a conventional trial, because there we really see the younger patients and not the older ones. And it's also that normally oncologists or nurses ask patients, and they sometimes decide to don't ask older patients. But with this design, you just select patients and then they get the offer. Also, physical activity levels are really low, 17 minutes and 11 minutes per week in the intervention and control group respectively. So this is really, also this is the selection we made, of course, but these are the patients who need these interventions. So let's look in more detail in the reasons. Here you can see the ones who agreed. There were some patients who said immediately, yes, I will do this. Other patients hesitated a bit because they were really in doubt whether they were able to exercise, but then they decided to participate. Others said, yes, this is precisely what I was looking for to overcome cancer-related complaints. Or I was already motivated to exercise, and this is really what helps me to start. And here, this one also shows something we learned from that design, that were patients saying, oh, this is a good opportunity to follow up on a previous program I followed. And this is, we select patients from the physical activity questionnaire, but we know that there is measurement errors in the questionnaire. So it could be that patients say that they are less active as they actually are. So it might also be that you ask patients who are actually more active or just had followed a rehabilitation program and decided that this was no physical activity which should be mentioned in the questionnaire. So that is also going to the nose. You can see that the last point is that some patients said, I'm already active, so I don't need the program, and therefore I do not want to participate. Others said, I do not like exercising. This is also the second one. I do not want to be confronted with the past, so with my cancer disease. This is not an answer or a no related to the intervention. This is more a no related to the phase where we perform this study. This is also something we hear more often in cancer research, that after a while they just say, we want to go on with our life. Others said it's too demanding now, physically or in time. No reason. Also, some patients did not give reasons. And then here, then there was one thing I would like to mention, because you can now see there were patients saying yes and no. And what we did, we recruited in waves. So we also had a group of patients where we did our recruitment. And also because we wanted to see whether the timing of asking in the year says something about the percentage of patients saying yes. And what you can see, we started in October last year, 58% said yes. January 59%, and in May 67%, so that's quite comparable. But then we did one wave in August, and we had some discussion before that. Should we do it in August? Is it end of holidays and perhaps they don't want? But then we thought, okay, this is a methodological study, so let's do it because we can learn of it. And unfortunately, as you can see, indeed, here we have the lowest participation rate of all waves. And now in December, so in a few weeks, we will do the last wave. And then we will see what participation rate is then. And this also shows us that within 1.5 years, we completed the whole study. And normally, exercise oncology trials have a duration of 3 years or longer. So this is also an answer to one of the questions. So let's move to the last group, which is quite an interesting group because we haven't thought about this group before we started the trial. And this is the group of women just telling maybe later. So they were offered that program and they said, oh, I'm not able now, but please call me in a few months. And reasons here were I'm not able at the moment for medical reasons. For example, we had a woman who said, I will have heart surgery next week. And another woman said, yes, I have a knee injury, so please contact me when this is when my knee is better. And there were also others saying it's too demanding at this moment, but I think in a few months I will be able. Or there was a woman saying, it's winter now, please call me in the summer. And in August, yeah. And also the percentage seems quite low, the 5%, but in total, the percentage of women saying maybe later was 17%, but now some of the women decided to go to no or yes. So because of that, it's now 5%, but in total it was 17%. And that brings us to two questions. The first is the ethical one, because before we started the trial, we did not think about how long our offer is valid. you know you offer an exercise intervention, and can we say, oh, if you don't want it now, then the offer is gone. And I think that I have no answer for this now, but I think it's good before you start a trial with an intervention to just think about it. And for now, I think it's going well because Roxanne just talks, I'm almost ready, just talks with the women, and they decide together when the offer is not valid anymore. But it's good to know that this can happen when you just send letters to patients with this offer. And the second one is a methodological one, because normally, and it's below at the slide, so some people cannot see it, but it's what I mean here. Normally, we defined a time window to get our evaluation measurements. So we have either at 12 months or 18 months post-recruitment that patients go in the trial, and we use the data 6 months later. And within this 6 months, the 12-week exercise intervention occurs. But patients who say maybe later shift in time. So it might be that they shift from this window to a later phase. And that's something we are still working on that, and we will only have an answer when we finish the trial and we really looked into the data. Because we now need to think, if you really take the intention to treat very strict, then you say everyone who is in the trial also will be analyzed there, and we will just use these time windows. But we already know that the exercise intervention was later. So this is something we will sort out next year. So this was what I wanted to tell you about the Umbrella Fit study, and we expect to have our results next year. So thank you.
Hi, so I'm Sean. A quick question, it's a point of clarification, and I could have asked, Rudolph as well, we ran out of time.
Okay.
So, yeah, in the intervention group, I think you said you had there were 65, and then some said yes, some said no.
Yes.
Control group, 65. So when you come to and this is this is the point of clarification for this design, when you come to do the analysis intervention group compared to control group, are there 65 in your intervention group?
Yes.
Okay, so you'll follow up the no's because you have the data anyway.
And we randomize, and you want comparable baselines. So that is, of course, we will also do some analysis with instrumental values to just see what the effect is of the nose, and you don't know the nose in the control, but you can perhaps predict nose in the control.
It's sort of intention to
treat. But the first analysis will be intention to treat.
Okay, thanks.
Yes.
Anna Biddy from Bristol. I was just wondering, I was interested in your timescales, and I'm guessing that your ladies with breast cancer who have had treatment have a relatively long prognosis. But this relates a little bit to those who say maybe later, but also the fact that you're recruiting them to the trial at 18 months. Is there a concern about survivorship bias, or that your short survivors have died in that time, or does that just not happen in breast cancer?
No, actually in breast cancer, survival is very good, the 5-year survival. But still, I think it's where you generalize to, and this is our randomized trial, and we just do it in this group. But what we now decided to do this first study in this later phase, but I think that probably the results we have with the yes/no might not be generalizable to during treatment phase, because there are other reasons might occur.
Yes.
No, I just noticed that across the umbrella cohorts, approximately 15% of those who are happy to participate in the cohort say no to the broad intervention. Well, it was 86 and 84 in the other part.
Yes.
So they give consent to the cohort, but not to the random allocation intervention. Have you been able to look like who they are, in what way they are different, and think how representative the results?
Actually, there will be a presentation tomorrow on more details on the no's and yes in the beginning, but I'm not sure. Do you also have looked into the characteristics of the yes and?
We did colorectal So, especially for those people.
There are a lot of people working in interest in the cohort.
We get show of hands.
There's a whole row over there.
Okay, one of them, please.
We did actually look into the differences and characteristics between patients who said yes to broad consent and patients who said no, and the differences were only marginal. So patients were slightly younger who said yes to broad consent, but the differences weren't clinically relevant.
Have you looked at education?
That's not one of the variables we've looked at.
Okay,
One of the
that's
variables we've looked at right now, but that's definitely something we could look into.
But this affects your generalizability and not your value.
That's true.
So, with regard to the methodological question about maybe later,
Yes.
I guess I would think that probably what you should do in a cohort trial is define when you're measuring the outcome, and then up to that point, anybody could start the intervention. Of course, they might not complete it because they might have started too late, but that would just be like partial compliance. If you like. I mean, some people start a treatment and only take half the pills, or somebody might only do half the sessions and so on, and then they only do the half the sessions because they started late. So I think methodologically, at the outset of the trial, you should define the point at which you're measuring the outcome.
Yes.
And then you try and get them to do as much of the intervention as they can, and maybe they start late, maybe they don't. I wouldn't worry about that.
Yeah, I think that's how we will analyze it. But it's because it's a 12-week intervention and a 6-month window, the chance is very high that it shifts.
Yeah,
Yeah, and then we will have more
I think
no's.
that's fine.
And one of the reasons also, because we have the fixed moments in time where we collect the patient-reported outcome measures, but one of your main outcomes is not collected at each time point. So for instance, the squash questionnaire isn't collected every 3 months. So there are some intervals where we skip the squash actually, so that's why it's also partially.
Well, you do have a primary outcome.
Yeah, and this is
Yeah.
collection.
Well, that's I'm afraid that's what's defining the window that I'm talking about. Then, right?
Exactly, that's why
I mean,
the
I think
window is
these-
so variable.
There's a whole raft of questions which aren't being addressed today, and not tomorrow, about design issues around the cohort trials, like, should there be primary outcomes and all that sort of, what of the baggage in conventional trials needs to be transferred over, and that's a whole separate raft of questions. But the sort of primary outcome question would be one, which I think probably does.
Can I
Yes.
sorry, I just wanted to ask, there's a kind of assumption at the beginning that the control group should be unaware of the trial going on. Is that ever assessed in the feasibility work that you do?
Now, I think that in this situation, they are not aware because they don't meet anymore. But we did actually, before we start the PACT study, we did a sort of cell design study where we indeed only informed the intervention group, but they met at chemotherapy, and at the end, everyone knew. So that's tricky in some phases, but in this phase, I don't expect that they
So
know.
that's raised a very big question, again, which applies to all trials, about how social media have now caused contamination between arms in all trials. And this isn't just a problem, again, for cohort trials. This is just a broad trial. Our naive assumption in statistics that the groups are genuinely independent, unfortunately, is no longer strictly true. Sometimes it's very, very untrue.
I've received orders from a high level that we might be done with Q&A, so let's stop. Excellent talk, excellent discussion.